All right, well, I think we'll go ahead and get started, and hopefully we'll have a couple more folks joining here shortly. But we've got a kind of a quorum of folks that are here, so that's great. I'm Dr. Ford, Pediatric Endocrinology. I direct the endocrinology division here at East Tennessee State University. We're trying to use ECHO as a way of educating providers throughout Tennessee and really our whole region about various endocrine topics. So this is supposed to be interactive. So if you have a question, let me know. Also, you'll at one point you'll need your cell phones because we'll be doing some online polls. I'll give you a phone number and then you'll text my name, George Ford 678 to that. We'll get to that in the PowerPoint, and then you'll notice there'll be several opportunities throughout the PowerPoint to input your answers, and we'll see kind of what everyone puts in and then discuss. Trying to keep it interactive and interesting. But again, also I'd love to just, if you have a question, feel free to stop me. Sometimes that's our best discussions. So, all right. So let's see. I'm trying to see my mouse, but I can't see it. Okay. Okay. So you should be seeing my PowerPoint popping up here. It's thinking about it. The computer's thinking. There we go. All right. Welcome to our Puberty Echo. We're going to talk a lot about puberty today and things to be thinking about as you see your patients that may have puberty-related problems. Hopefully it'll be something that leaves you with things you can apply in helping your patients. I have nothing specific to disclose regarding puberty. No one's paying me to talk about puberty. First, just kind of a brief review. The HPA axis that controls puberty begins in that first trimester, so that the infant can develop both male and or female genitalia. And then there is a mini puberty of infancy that we're going to talk about that usually starts around 2 weeks and then goes for a couple months, usually a little bit longer in girls than in boys. And that can have some implications for various things. And then that axis is supposed to be suppressed until the proper moment where GnRH will start pulsing at night. And then we'll have resultant LH and FSH interaction with the testicles or ovaries. So we've got the LH coming from the pulses from the GnRH. This is just kind of a little chart that kind of is meant to reflect the mini puberty of infancy that occurs in children. So that's going to happen between around 2 weeks, usually peaks at the 1 month kind of mark, continues into the 2nd month. And for some people, actually, there can be a bit of a tail where that lags all the way up to the 6th month mark. And again, more commonly having a little bit longer duration in females. If you were to measure LH and FSH during the mini puberty, as well as estrogen and or testosterone, depending on the infant's gender, you would get strongly pubertal levels of all three. And so it's a perfect opportunity if you have an infant that you're worried has some sort of pituitary problem or pituitary issues. It can actually give quite a nice glimpse into whether or not puberty may be one of those problems in the future. So kind of, again, just this is all mostly basic kind of going back. So in our hypothalamus, we do have GnRH. That's going to start pulsing during puberty, begins at night. Eventually it starts going both night and day. That will cause LH and FSH pulsatility. And resultant stimulation of the gonads and production of estradiol testosterone, which have negative feedback on the pituitary and hypothalamus. basic rules of thumb, if your LH and FSH is very elevated, that usually means that the gonad is not functioning, either it's been damaged or congenital disease is in play. Sometimes you have to be, if you have a high index of suspicion that someone, for example, has precocious puberty, but their LH and FSH come back prepubertal, you need to be careful with that because you may have missed the pulse. You may need to do or have an endocrinologist complete a GnRH agonist or Lupron related stimulation test to prove that puberty isn't actually started. One thing very critical is that whenever you send levels, if you do choose to look into LH and FSH, it's critical that they be ultra sensitive. Most LH and FSH labs completed at most centers are not. They basically will tell you that the child is not an adult, which isn't very helpful. So you need very sensitive assays. We send ours to Esoterics. They're very reliable. It's something to remember. A lot of the other labs, when people come with referral, the pediatricians have often ordered LH and FSH, but I have to repeat them because they're uninterpretable. Okay. So then we kind of have when will puberty start. The best thing to always start with is the history, if we know it, for mom and dad. Moms are usually really good at knowing when their menstrual period started. Men are less likely to be fully helpful in remembering when their puberty started, but they often will remember when they had their growth spurt. Another thing that often you're going to try to order when you're trying to determine if something's going wrong with puberty is a bone age. And 2 rules of thumb that are really helpful to remember is that if a girl has a bone age of 11 or a boy has a bone age of 12.5, that should be a pubertal bone age. So if you have that bone age and there's no signs of puberty on exam, something has gone wrong. If you see that bone age in someone who's only 7, then something's gone wrong in terms of precocious puberty. The one thing to always remember about bone age that kind of complicates it, especially since about a third of children are now obese, is that if you're at a higher body mass index, it does kind of predispose to some premature pubarchy. It also will advance your bone age by a year or 2. And so in those obese patients, they're a little more complicated because it can throw off the bone age, and you may think that that patient has started puberty when they have not. Okay. So we'll start with this one. Patients in PCPs. Oops, sorry. Jump to the next screen. That's going to be our next first poll. So a 15-year-old male comes into the PCP's office. They're here for a well child check. You haven't seen him for 2 years. They basically really don't have any issues to talk with you about, but he does note he's been kind of feeling like he's short. He's been healthy. You notice on exam 10 or 1 pubic hair and penis and 2 to 3 milliliter testicles. Getting at the history, dad thinks his puberty was a little later. He thinks he was about 14. So they figured he was just kind of following dad's lead. He is concerned that his lack of growth is going to start affecting his sports. Okay. So this is where we're going to start taking some polls. So pull out your phone. At the top, the phone number that you're going to is 37607. So 37607. And then you're texting George Ford 678. Then once you've joined, it'll give you the opportunity for you can just put in the letter A, B, C, D, or E to answer this question. And so again, 37607, text George Ford 678. And our question is, what would be the most helpful first-line test for this patient that you're seeing? Thyroid function panel, LH-FSH testosterone, growth factors, bone age, or brain MRI. So far, we're getting a fairly strong response for D.
It works, send it to me. The text.
What's that?
If they can't send it to you, send it to text.
Oh yeah, if you're having any problems with, or you don't have a cell phone, just you can text on the side there your answer, and our tech guy can tell me what you said. Looks like for now we're getting a fairly good consensus on bone age, which would be the best answer. Bone age is such a great first-line test. What would people expect for the bone age on this patient? So you'll have to unmute your microphone to answer. Anyone want to take a stab? Pleading the fifth. So in this case, obviously our physical exam is showing some issues where we would expect the bone age would be delayed in this patient.
I would expect it to be like 12.
Okay. Yeah, it would definitely be probably that or even younger. Yep. Very good. So based on that information, we'll say the bone age is delayed to 11.5, 12. You're starting to wonder about this syndrome: Klinefelter syndrome, Kallmann syndrome, glycogen storage disease, hyperthyroidism. No idea. Please refer to endocrinology. Okay, we've got a vote for hyperthyroidism. We've got a vote for Kallmann syndrome. Now we're split. No one wants to pick glycogen storage disease. Right now we're 50-50. Any other text responses? Okay. So it looks like we kind of got split between Kallmann syndrome and hyperthyroidism. The best answer in this case would be Kallmann syndrome. Obviously, I didn't give you much of a history of whether the patient thought they could smell well. The thing to remember with Kallmann syndrome actually is you don't always have a complete lack of smell. You can actually be on a spectrum. And I actually have had patients who've endorsed that they could smell, and then later on, as we kind of really looked into it, realized they don't truly smell very well or not at all. So that's not always the most helpful. I try to ask people if they step in poop, can they smell it? That's one of my questions. There was really nothing in our case that suggests hyperthyroidism, and hyperthyroidism is not classic for presenting this way. In terms of delaying puberty this much, it would have become clinically evident when he was younger. Other options on here: Klinefelter syndrome. Usually you're going to get some puberty that starts and then fails. You're going to have smaller testicles that are barely in the pubertal range, that are going to be very firm. Some people with Klinefelters can get through the rest of the stages of puberty in terms of Tanner staging for pubic hair and penis, but their testicles remain small, usually in the 6 to 7 milliliter category. Okay. Any questions about that case? Hopefully a good primer to get us started. All right. So now we have another patient in the office, this time a 15-year-old female. Her complaint is her periods have stopped. They started when she was around 11 and a half, but then stopped 2 years ago. She says she's healthy, immune system's pretty boring. She has seasonal allergies. There's a past medical history. She is short for her family, but family's never really been concerned about it. She's growing at the 5th percentile. Mid-parental height is closer to the 25th percentile. Definitely underweight. BMI is less than the 1st percentile. She's not at all dysmorphic appearing on physical exam. And she has reached 10 or 3 kind of uniformly for her puberty on exam. So everyone got that case in mind? So now we're going to, again, kind of give you an opportunity to share your thoughts. What is the next best step for the PCP? So we have A, reassure and check thyroid and prolactin levels, maybe start an OCP. B, send to endocrinology with a bone age. C, assess ultrasensitive LH, FSH, and estradiol levels. And D, discuss the possibility of an eating disorder, given that she's at the 2nd percentile for weight and BMI is less than the 1st. Okay, so far we have 100% for C. Any other folks texting? Okay. I'm hoping everyone has it working at this point in terms of being able to contribute to the poll. Okay, so certainly this is kind of a little bit of a trick question because most of the things listed there are very appropriate. Certainly assessing the LH, FSH, and estradiol levels would be very appropriate in this situation, given the cessation of menses for the last 2 years in the patient. Thyroid can, and profound hypothyroidism can cause issues with cessation of periods. Abnormal prolactin levels as well can do the same thing. Usually high prolactin levels will do that. We sometimes see that with some psychotropic medications. And then bone age would be very, very appropriate in this patient, given that they're shorter than expected and puberty has stalled. And you would want to kind of know, is something else going on? We've met several of these people, and they've turned out to have eating disorders. You also may have your overachieving, straight A, dances 4 hours, runs 4 miles person who's got some hypothalamic related inhibition of periods. Anyway, so, but C would be very appropriate, which is what everyone kind of opted for. Oh, and then D. Someone just throw in a D. But yes, D would be something you maybe would probably actually discuss before you would send, obviously, laboratory work. Okay, very good. Thank you, everyone, for your participation. So again, coming back to our axis, things to remember, in our first case, if we got the LH and FSH back, and that was a real case, in that case, we actually did get very low LH and FSH. Clearly puberty had not jump-started. We talked about hyperprolactinemia. That can also cause puberty to stall. Usually you're going to be more worried, especially if you're getting above 100 on that prolactin, and certainly anything over 300 would make you worry about a prolactinoma. Some of those psychotropic medications like Abilify are kind of classic for also causing problems in this area, and often also will cause some galactorrhea. And then again, we kind of talked about that functional deficiency. That could be either from an eating disorder or just excessive exercise, of which we've had many patients present with that. Critical ones to remember for gonadal failure for girls would definitely be Turner syndrome, Puberty, galactosemia, and of course chemotherapy. And then for males, Klinefelter's vanishing testes syndrome, of which I do have several patients who've had that, and of course several who've had chemo or radiation. Okay, so now we're going to try to decide when are we worried about puberty. It's late if it has not started by this age. So A's boys 15, girls 14. B, boys 14, girls 15. C, boys 13, girls 12. D, boys 14, girls 13. And then finally, boys 16, girls 14. So I'll give you a second to key in your answer and or text it. So far, we're getting kind of a split between D and E. Okay, so the answer is D, boys 14, girls 13. So if you have a child coming in at that age and they have not started puberty, which for girls, they really should be having breast development. So if there's no breast development by age 13, that would be considered abnormal. And boys, if there has been no testicular enlargement and usually some early signs of puberty with pubic hair and so forth, that would also be abnormal. That's because approximately 95% or more of boys and girls have entered puberty by that age. So anyone who hasn't is an outlier on that curve. We do sometimes meet people who are referred very late. I've had a patient, girls as late as 17 and boys as late as 18 be referred for lack of puberty. They definitely would have benefited from a significantly earlier referral. Okay, so this is an interesting slide because it's probably a little different than what people remember from medical school. It's more recent studies about what is the normal range for puberty. Some people kind of find some of these ranges a little hard to swallow, but prior studies were mostly just based on Caucasians. This study tried to include minorities and others to see kind of when normal was for those minorities. Welcome, Dr. Hudson. You're on microphone.
Thank you, sorry.
You're fine. We're happy to have you. You can kind of see here on the slide for girls, the youngest that's considered normal for early signs of puberty is 6 for African American and 7 for Caucasian, with a mean though of about 9 to 10. And again, abnormal if you haven't got any or you haven't had any signs of puberty by 13. And then boys, kind of basically everything goes up in 1 year. So 7 for African American males, 8 for white Hispanic. Mean start time was still around 9 to 10, but that for boys is very early starting. Like that would be just seeing a testicular volume moving from like 3 to 4 cc's. You're usually not going to see a lot of other big changes at that point. And then again, abnormal for boys if they've gotten to 14 without signs of puberty. So, you know, especially if you see a boy who's 14 and their testicles are still prepubertal in size and that kind of 2 to 3 milliliter ballpark, that should get your attention. So
I have a question for that.
Yeah, great.
This is Dr. Jogel. So African American children and adults, they have a higher prevalence of obesity.
Right.
Does that skew that age to be lower? So what if their BMI is normal?
That's a good question. I can't remember for sure if this study corrected for BMI. I don't recall when I read the study that they thought that weight was a contributing factor. However, as you noted and has been noted previously in the show, obesity is something that often will cause some early signs, often some premature puberty. And so I would have to go back to the study to make sure they actually controlled for BMI. But as far as I recall, I think that that was true regardless of weight. It is a confounding factor for, I think, both generalists and endocrinologists because it confounds bone age. It often does, people will get a lot of adipose tissue in the breast area, and sometimes it's harder to discern if they've developed true breast tissue versus adipose tissue. Although usually you can really feel that kind of nodular breast tissue compared to kind of just the soft, squishy adipose tissue. But we do get a lot of referrals where people are feeling unclear or unsure on that. Because of obesity, it definitely is causing people to have, we do think puberty on some level has a BMI sensitivity to it. So as our population becomes more obese, we do think that is driving earlier signs of puberty. The actual onset of true puberty, though, does not seem to be impacted that much by obesity. Although, in general, periods for women are now 6 months earlier than the prior generation. So that has statistically changed, and we don't know why. And obesity is one of the possibilities for that. Did that answer your question?
Thanks, yes.
Okay. So let's see, where were we? Oh yeah, so, when to get concerned, boys younger than 7 that are African-American or white or Hispanic less than 8. Really, you should always be really concerned if you're seeing a boy with lots of early signs of puberty. That's more likely to be something that's not idiopathic, that is very concerning. Girls, on the other hand, have a high propensity to have early puberty that's just idiopathic. We can't find any anatomical or other problem. And of course, our favorite word, idiopathic, which means we really don't know. When would you be most concerned about some of these patients? Certainly if the tempo of the puberty is rapid. And we have seen this in a couple kids who were kind of starting almost near the normal time, but then their rate of puberty was very abnormal. For example, boys usually take at least 5 years to get all the way through puberty. And then, bone age rapidly advancing. Certainly, any CNS findings or CNS complaints, blurry vision, new chronic headaches. And we do know that when people go into puberty early, it does create problems. Studies have shown increased risks of depression, anxiety, early acting out behaviors, early sexual debut. And obviously it's going to attenuate height since their bone age will be pushed forward quickly and they'll end up shorter than expected for their family. Any questions on that section before I move? Okay. So we're going to go on to a case because this is a very common case that we get. So this is a 3-year-old girl. Mom is really concerned about the breast development. What would be some of the questions we'd want to know? Oops, I don't want to show you. What would you want to know about this patient? Maybe we could have just one of you try to weigh in here. Dr. Hudson, could you do that for us? I'm going to single you out, Dr. Hudson, if you're still there. I don't know. I might be on mute. I don't know.
Sorry, you were on mute. Did you ask me a question?
Yes. I was just wondering, in this case, what would you want to know, Doctor? I'm just, we're trying to think about this 3-year-old girl where mom's concerned about breast development.
How long has it been there? Is it on both sides?
Okay, so duration, onset, very good. Anything else that you'd want to get from mom?
Are there any other signs of puberty? Is there pubic hair, axillary hair? She had rapid weight gain.
Good. Yeah, so that's perfect. So yeah, I mean, a lot of this is going to be really helpful from the questions you ask the family. You can also, get a history of the family in terms of when their puberty started. So kind of going with that. So kind of answering many of Dr. Hudson's questions. Mom first noticed some breast development in the newborn period, but then it kind of went away for the most part. Around 1.5 years of life, left breast seemed a little large. Then around 20 months, the right started to get bigger. And then now the nipples seem really prominent. You do ask for other signs of puberty. The family says there's no vaginal bleeding, no body odor, no acne, no oily skin, hair. And then in terms of family history, everyone basically had their puberty at a very typical time. No one was early, no one was late. So here we have your exam findings, which otherwise exam was normal, except for there was bilateral 10 or 3 breast tissue, no pubic hair. On history, you find out that mom was 64 inches and dad was 69 inches. I've intentionally made that math easy because in order to get a mid-parental height for this girl, we would just make dad into a girl by subtracting 5 inches, which conveniently makes dad 64 inches, and thus the average between them would be 64 inches. So that gives you a sense of mid-parental height. I hope you can kind of see the growth chart here, but you can kind of see on the top her length. Looks like she had previously been growing somewhere closer to the 75th percentile, now growing around at about the 95th percentile. And then for weight, it looks like she was, there's not a whole lot of data on her weight, but she was previously above the chart and now is below the 90th percentile for weight. So now we'd be asking questions like, what are the possible causes of this early breast development? What evaluation helps to sort this out? So we'll begin by polling our audience. So based on the information we have so far from the family and the exam and the growth charts, what would be your thought? Would you A, reassure the family and tell them the degree of puberty and growth are normal? B, reassurance, development is limited to the breast and her growth is normal, so there's only breast development, so probably okay. Concern, breast development is abnormal and growth velocity is too fast. D, concern, breast development suggests late onset congenital adrenal hyperplasia. And E, reassurance, degree of puberty is normal and likely from mini puberty of infancy. A little harder question. Some folks answering C so far. Okay, so seem to very commonly get this split between 2 answers. I must be somewhat predictable. So it looks like we got half of the respondents saying reassurance. Oh no, ooh, we switched to 60-40. All right, C is now winning. So B, we got 40% who feel like reassurance is all right because there's really just some breast development. Growth is pretty normal. And then we have concern that both are essentially abnormal. So, going back, 10 or 3 breast tissue in a 3-year-old is abnormal. And in this case, mom was really also describing breast buds occurring prior to this 10 or 3 stage. And the history also suggests that she did have some normal kind of breast tissue that formed in the mini puberty of infancy, but that regressed. And the fact that her breast tissue is advancing and her height is well above her expected growth potential for her midparental height and has gone up significantly from previously. Usually a child, once they got to around age 3 to 5, they've kind of found their channel on that growth chart and are usually going to stay fairly steady on it. So in this case, yes, the answer would be C. We would be concerned by the breast development. Now, a lot of these cases don't turn out to be nearly as impressive as this case. Often people will have a little bit of breast tissue that's just remnants from mini puberty of infancy. Having some palpable breast tissue underneath the nipples would be normal for girls. Getting a good history of how it was when they were a child versus now is very helpful. Breast development should always get you, if it's true breast development, should always get you worried more about central precocious puberty. In a lot of these girls who've had breast tissue that's formed in that mini puberty of infancy, it does regress, just like in this case. Any questions about that? So, in this case, we would be actually worried about true central puberty. So you would get at ultrasensitive LH and FSH and ultrasensitive estradiol. Her growth velocity is quick, and she's much taller than expected. One thing that would be very rare for this patient would be an ovarian or adrenal source of estrogen driving true central puberty. That would be probably less than 1% of cases like this. Okay, any other questions about our first case?
Would you prolactin levels?
Yeah, so kind of as mentioned earlier, other things you might consider in this case are, you might consider getting a prolactin level. You might also consider getting thyroid levels. If this case were a little bit different, say someone came in complaining of kind of isolated vaginal bleeding, but did not have true breast development or pubic hair, and they're trying to figure out what's going on, and you're going down your differential for vaginal bleeding. One of the things that you should think about there would be thyroid, profound hypothyroidism, especially if that TSH is significantly elevated, above 150 usually. That TSH has a sub unit that is shared with FSH, and so the TSH will actually act on the FSH receptor and can cause menstrual bleeding. That's called Van Wyk-Grumbach, and I've actually had 5 or 6 cases of that in my career so far as an endocrinologist. And once you treat their hypothyroidism, they stop bleeding. Yes.
Is this ultrasensitive LH and FSH available at AEL? Does anyone know? Also thinking of McHugh and Albright.
Okay. So I don't know the question about the AEL.
AEL.
I'm I'm not sure what AEL is.
They are long temporary ones.
I'm not sure. Most esoterics, like I kind of said earlier in the program, is our best and most reliable one.
Sorry, AEL is our lab that we use here in Memphis. And so my question was mainly to the other providers if we know that we get this ultrasensitive LH and FSH, because I've not seen that on our system.
Anyone who's in that system who would know that answer?
Dr. Wallace, it looks like you're trying to talk, but your microphone is on mute.
Yeah, I was trying to get it. Yeah, I would think not that if you ordered it through our system, it would be not the sensitive one, and that would hold true out east as well. But I think if it came that we needed that particular test, we'd have to talk to them. They would have to send it out to probably another reference lab, as noted. But if we get to that, let me know, and I will help facilitate that.
Thank you.
And then yes, you could think about McCune-Albright in this situation. The patient's missing lots of the other features that you would typically see in McCune-Albright. At least I certainly didn't mention them in the history and exam. Okay. So case 2, we have a 7-year-old presenting to clinic just for their regular exam. On exam, though, you notice there's underarm hair. And when you get to the general exam, 10 or 4 penis and testes are 2 cc. On questioning the family, you find out that he's a twin and that he's always been a lot taller than his twin. You thoughtfully, based on everything we've talked about, get a bone age and find that it's 11. Well, actually, this came to you previously before this case. The bone age was 11 when the child was 6. So that this is when they finally get into you for evaluation. So the bone age is clearly advanced. This is kind of an example of how the patient looks on physical exam. And then you have your growth chart here on the right. You can see we've got some data going back to about age 3, and the patient has gone off the chart for stature as well as weight. So based on, I obviously am not giving you all the information in the world, but based on that information, which diagnosis would you most be worried about? A, central precocious puberty. B, Fragile X syndrome. C, exposure to clomiphene or other estrogen receptor inhibitor. D, Sertoli cell tumor. Or E, familial male precocious puberty. Okay, we've got a couple right now. We got some folks favoring Fragile X and 33% for E. Going back and forth. It's like watching an election right now. It's just going back and forth. Fragile X, familial precocious puberty. Okay. Well, I'm gonna close the polls, I guess. So we've got 71% voting for Fragile X, and then 29% voting for familial male precocious puberty. So this actually was familial male precocious puberty. There's several things about this case that don't fit with Fragile X. One is there's really no developmental history given that the person is delayed or has developmental delays, and Fragile X almost always would. Testicles in Fragile X are usually larger and than normal. And these testicles are actually quite small. In fact, the biggest thing about this case that should strike you immediately is the testicles are prepubertal, but the person is not. So that's a major clue in this case. Things we would, it wouldn't be the only thing on the differential diagnosis. I didn't give you everything. So other things you would think about in this patient is severe non-salt wasting CAH. In CAH, usually you're going to obviously have some early pubic hair and body hair. If it's undetected and someone has non-salt wasting CAH, that will eventually push the person into early puberty and they'll start showing signs. However, in this case, you would get normal LH and FSH stimulation of the testicles, of which the testicles would then become pubertal in size, followed by changes in penile length and other signs of puberty. Textotoxicosis is just another name for familial male precocious puberty. Basically, it's a defect in the LH receptor. The LH receptor is self-activating and causes the child to make too much testosterone. Testosterone cells make up very little in terms of the actual bulk of the testes. When someone's going through puberty and their testicles move from prepubertal to final adult size, most of that increase comes from FSH, working on Sertoli cells and Sertoli cell maturation. So in this case, the very, very small testicles, but then having this kind of full puberty moving along is highly suspicious for that. I've listed Klinefelter syndrome. Klinefelter syndrome does have a higher rate of precocious puberty and would have testicles that would generally be smaller than expected for the degree of puberty. But even in this case, you wouldn't expect to see prepubertal testicles with this degree of puberty. You would more typically see kind of somewhat pubertal testicles that are very firm, kind of the texture is different, kind of hard to describe, but and so in those, that kind of would be a tip-off for Klinefelters. Obviously, you could have other signs that come with Klinefelters in the patient. And then an HCG secreting tuber. An HCG secreting tuber would work on the LH receptor, so it would present very much like this case, where you'd have small testicles but lots of puberty. But HCG secreting tumors in this case would be unlikely just given the duration of the symptoms. It's also a very rare diagnosis. So kind of a harder case, but hopefully a good learning case. One of the biggest take homes, so I want people to remember, is whenever they see puberty and testicles that are not matching up, that should be a big red flag. Okay, and obviously the age of this puberty is a big red flag. All right, so now we're going to talk about something that I'm sure comes in quite frequently, concerns about delayed puberty. I found, when I first Googled this on, I found this Justin Bieber picture and it just seemed perfect, so I had to use it. You know, what are our main causes of delayed puberty? There's multiple potential things happening. In terms of pathology, it could be a chronic illness. So we certainly have had people who are presenting with a GI illness, inflammatory bowel disease, and any really inflammatory condition is going to cause potential problems with puberty, kidney issues, eating disorders, more common in girls and boys, but we're seeing more and more boys developing those now. Your most common reason for delayed puberty, that's a diagnosis of exclusion, which is frustrating because that means you're excluding these other things on this list, would be constitutional growth delay, or also delay of puberty. And then obviously they could have a hormone deficiency. Often that would cause a bone age delay, as in hypothyroidism or growth hormone deficiency. But constitutional growth delay also causes often a delayed bone age. So that complicates answering that question a little bit. And then obviously you could just have failure of the hypothalamic pituitary gonadal axis, as in Kalman's, other syndromes, or if something else has happened, such as an injury to the pituitary stalk. So, well, this may be easier to answer now, but which of the following would cause delayed puberty? Exogenous testosterone, chronic illness, HCG secreting tumor, eating disorder? Two of the answers above are true. I kind of gave you the answer. I got to remember to put that slide before the. Anyway, but yeah, so in this case, obviously an HCG secreting tumor would actually cause significant pubertal advancement, and so would exogenous testosterone. We do get a good question to always ask any of the, going back to the prior case, is to ask whether anyone's using exogenous testosterone in the household. We have had several cases recently of children developing signs of puberty on exam, only to find out that Uncle Joe is using testosterone gel. Good thing to know about all those gels is they're very, very transferable. Just has to go through the shirt onto the skin of the other person. It will transfer to other things in the house, like upholstery. So if someone's always sitting right where grandpa sits, and he's getting his testosterone on that chair, they will get virilized from that. And we've had both males and females having exogenous testosterone exposures. Okay, so now just kind of a this would be a typical question people might ask about development. In girls, how soon after the start of breast development would they have their first period? A, within 6 months in about 75% of girls, less than a year most of the time for B. C, in about 2 to 2.5 years. D, within 2 years or it's late. And E, no clear correlation between breast development and start of menses. Why are you asking this question? Ooh, oh, finally got 3 answers. Yay! Okay. This seems to be a better question because we're getting more answers. Or different answers, I should say. So we've got 29% for B, 57% for C, and 14% for D. So the general rule of thumb is C, about 2 to 2.5 years. D isn't totally incorrect because if nothing's happened after 2 years, that should get your attention at least. It would not be abnormal for it not to happen within a year. In fact, if it did happen within a year, that would be kind of an increased tempo of puberty that also might be concerning. Okay. I already kind of mentioned for boys, a good rule of thumb to remember is from onset of puberty to the finale, it's going to be about 4 to 5 years. So again, the rate of puberty matters. If someone's tempo is completely off and they're rapidly progressing, or they kind of stop progressing, that should get your attention. So what is the most common cause of delayed puberty? Hypothyroidism, growth hormone deficiency, genetic disease, familial short stature, or constitutional delay of puberty. kind of fun to watch the real-time results. Like, ooh, we're getting a lot more controversy on this one. I like it. Although A and B seem to be shrinking. Don't think they're going to win the Electoral College. Okay, so we got 14% for hypothyroid, 29% for growth hormone deficiency. No one liked genetic disease or people being genetically short. And then constitutional delay of puberty. And the answer is E. And typically you are going to get a history from at least one parent that they were delayed, unless dad's just not helpful. But, you know, you'll often get a history of mom having a late menstrual period, dad growing very late in high school, and being a midget until he finally got to his junior or senior year. Again, it is a diagnosis of exclusion, so you do have to be thinking about these other things. Hypothyroidism is much, much more common than growth hormone deficiency. Growth hormone deficiency only happens about 1 in 50,000 individuals, and we have no other history that would suggest that that's happening. But again, you'd have to exclude that potentially as a diagnosis, as well as hypothyroidism. Other causes of puberty, such as genetic, are less common than the other ones listed. And of course, familiar short stature will make you short, but it shouldn't affect the timing of your puberty. It might, I guess people might be shorter than expected if you find that people were having early menses or other things like that, that might explain why people are very short in the family. Okay, so this picture is supposed to be very representative. All the boys in that picture are the exact same age. So it kind of shows you how dramatic the impact is on a developing child in terms of the timing of their puberty. And then on the left, there's kind of a chart that kind of shows you kind of growth velocities and what happens to people. That first kind of yellow curve on the left is kind of early bloomers. The white lines peaking in the middle are people having puberty at the normal time. What you will notice is that people who are having puberty at the normal time are going to have an improved growth velocity and often will grow much faster than someone who has puberty too early. And you'll also notice that the growth time drops dramatically very quick in those early puberty folks. And then you'll also notice that the late puberty folks generally do not ever achieve the same kind of high levels of growth velocity as the peers who went through it at the normal time. However, they have had more time to grow at even a prepubertal rate, so their overall height for late bloomers is usually fairly close to their expected mid-parental height. Any questions on that? Kind of just a good chart to keep in mind as you're thinking about children that are coming into your office. We get a lot of referrals for families worried about puberty in boys and worrying about it not starting and not growing and muscle bulk and sports. It's a very common referral. So one thing that can be helpful as you're following someone, you can try to exclude these other causes, is watching how their bone age is. And in this case, this would be a very classic chart for someone with a bone age, with someone who's a late bloomer. You can see they're kind of growing right below the chart. Everyone's super concerned, but you get a bone age there and you find that it's really delayed. And when you trace it back on that blue line, you actually can look back and see, oh, well, that's actually the height percentile I expected for the genetic potential of that individual. So they're actually, the bone age corrected for their actual age is reassuring. And then you can continue to follow that bone age. One thing you'll note in that yellow curve is it kind of slows down and then really takes off. So something to remember in all your pubertal, both boys and girls, is there's often actually a growth deceleration just before a person enters puberty. And then the person takes off. We often get a lot of referrals right in that moment where that deceleration occurs before they hit their growth spike. And then you can see all the bone ages continue to consistently on those blue lines go back to the expected height. And as you can see, that yellow line actually did rise late in life and went right close to what we expected based on all those bone ages. So that's just a real nice kind of a classic chart of how a person might grow with constitutional growth delay. Okay, I think we're a little over time, but any questions? I'm happy to discuss. Any cases or things that have come up that people want to know? Such a quiet group.
No, I think it was a very good presentation, and that'll actually make us think, and maybe we will come back to you with some questions.
Okay.
As two cases, if that's okay.
That would be fantastic. In fact, we in kind of continuing these echo series, we're kind of trying to use this as a primer, but we're hoping that it gets people thinking such that they actually submit cases that they're trying to figure out so that we can actually present those and discuss them. So if you have interesting cases, please send them our way. We'd love to include them in our future echoes. Yeah. Dr. Long, can you share your full name and email address?
Ariel, just type it into the chat. Will it be okay? She can type it into the chat.
Okay.
She's from Memphis. She's one of my Memphis clinics. So.
Okay. Yeah. If you could, it doesn't look like Dr. Long's still on the line. Maybe you could text us the emails of your folks that are in Memphis so that we can make sure we're.
Yes, I will. We had two of our Memphis colleagues with us today, so I'll send that to you.
Excellent. Thank you. All right. Well, thank you everyone else for participating. We will be doing this again next week, same time, Thursday at 12. Our next one is one that people ask about constantly, thyroid. And I've actually tweaked my PowerPoint quite a bit based on feedback from our last thyroid echo series. So hopefully it'll be very high yield because it's such a common thing that's going to come up.